Welcome to Muslims and Mental Health with Sister Heather, a groundbreaking program looking at mental health issues through the biopsychosocial spiritual paradigm.
Welcome to another episode of Muslims and Mental Health. Today we're going to be discussing what is depression, and I'm going to be joined by Dr. Joseph Futerman, who is a psychotherapist and a professor at the Chicago School of Professional Psychology of Southern California. I'd like to begin by opening with a few facts about depression. Depression affects approximately 19 million Americans, or 9.5% of the American population, in any given one-year period. At some point in their lives, 10 to 25% of women and 5 to 12% of men will likely become clinically depressed. In fact, it affects so many people, it is often referred to as the common cold of mental illness. It is estimated that depression exacts an economic cost of $30 billion each year, but the cost of human suffering, of course, cannot be measured. Depression not only causes suffering to those who are depressed, but it also causes great difficulty for their family and friends and those who are around them, and who often don't know how to get help. So today we're going to hopefully empower you and raise your awareness about depression. And thank you, Dr. Futerman, for joining me today.
It's a pleasure to be here.
I appreciate it. And I want to start off by asking you just simply, what is depression?
Well, and that gets to kind of a problem often when we talk about what's happening with mental disorders. Depression is both a state that people live in and can experience. So we can all be depressed. Say, I go to get ice cream and they don't have any. I may be depressed about that, right? Mm-hmm. On the other hand, depression is also a diagnosis. And when a clinical practitioner talks about depression as a diagnosis, we mean a very specific constellation of symptoms. In fact, there are 9 types of symptoms that we associate with depression. You have to have at least 5 of those, and you have to have them continuously for at least a period of 2 weeks. And those symptoms are essentially a depressed mood, so being reporting that you are unhappy, tearful, very sad, a loss of interest in pleasure. The old term for that was anhedonia. I like some of the old words better than the new ones. These days we just say a loss of interest in pleasure. A weight loss or gain of 5% over a period of less than a month. Insomnia or hypersomnia, so sleeping too little or sleeping too much. Psychomotor agitation or retardation. Again, this means either not feeling that you are constantly having to move, or that you just don't feel like moving, don't feel like doing anything. Fatigue, which would often go with that notion of psychomotor retardation. Feelings of worthlessness, excessive guilt are also a symptom. What's sometimes called a cognitive fog, or the inability to make decisions, the inability to actually focus and be present. And then thoughts about death. Now, not particularly just fear of death. Being afraid of death is pretty much natural for everyone. But thoughts about your own death, and particularly suicidality, suicide, having a plan, even if you're not intending to carry it out. Mm-hmm. So you have to have at least 5 of those symptoms, and again, for a period of 2 weeks. And when a clinician talks about it, that's what we mean when we say depression.
Mm-hmm. And so sadness is a symptom of depression,
but
right. It's not considered depression itself.
No.
So I just want to distinguish that, because
you can be sad for a long time. Some of us are very sad about things. For instance, in the case that a loved one has died, mm-hmm. you can be very sad for a long time. A life situation, you can be sad, but without the other symptoms, you would not be considered clinically depressed. Again, you might describe yourself as depressed, and that would be perfectly appropriate. But in terms of the diagnosis, no.
It's just more colloquial.
Yes. Mm-hmm. We need better words in our field. We need to develop new and different words, because we use words that everyone uses.
Right. And so along those lines, there are different types of depression, correct? And could you tell us about the different types?
Well, and here you end up with a little bit of a theoretical problem because different theories see different depressions. But if we go to just the diagnosis, there are about 11 different types of depression. Now, the depression I just described is essentially what we would call a major depressive disorder. And the facts that you read mostly refer to a major depressive disorder. You can have, according to certain theories, that be either a melancholic depression or an agitated depression. In a melancholic depression, you are, again, more sad. In an agitated depression, you're more irritated. So that person who constantly finds things to be irritated about and is never happy about anything could have an agitated depression. It might be that they're not just somebody who is a constant pain. Mm-hmm. They literally are in pain, and that's why they're there. We used to use a term, again, I like the old terms, dysthymia, mm-hmm. for what would be considered a chronic depression. These days, we call it persistent depressive disorder. Mm-hmm. And that is a lower level of the same types of symptoms I described, but over a period of 2 years. Mm-hmm. And again, we do see that occasionally. Bipolar disorder, which most people think of as having to do with the manic side. We think about the crazy side where people are up and think they're capable of doing anything, flying. I had a patient at one point who felt that he was capable of passing through cars, so decided to go for a run across a freeway. It did not turn out well. But the other side of it is the depressive side. Mm-hmm. And so we speak of bipolar disorder or a bipolar depression. Sometimes we'll also speak of a major depressive disorder as a unipolar depression and bipolar disorder as a bipolar depression. Seasonal affective disorder, which most people don't get in this area where we are, Southern California.
Sure, in the Midwest.
But in places where you have a significant change in the light, we think that has to do with a change in the light. And again, people will move into a mood where they are consistently on the sadder side, less happy side of things. We now speak of psychotic depression at times, some people do, or depression with psychotic features. A person can have a psychosis, which means that they suffer from delusions, ideas that are clearly not real, and or hallucinations. A hallucination is literally a sensory experience. I see or hear or feel things that aren't perceivable by anyone else. And along with that, depressive symptoms. Again, the symptoms we talk about. Postpartum depression, we also have antepartum depression. Some people get depressed when they become pregnant. It is, after all, a challenging physical condition. Mm-hmm. And some numbers have put the numbers as high as 60% of women can suffer from postpartum depression, so that after they give birth, there is a sense of loss.
And for up to 2 years, right?
And for up to a couple of years, yeah. Premenstrual dysphoric disorder is considered now a depressive disorder. And again, this is where you have a monthly bout around your menses, essentially, of the depressive symptoms. We have, of course, situational depressions, and a situational depression is also, in the old days, what we would have referred to as an exogenous depression. It is motivated from the outside, and, appropriate situational depression is normal. You lose a job. You don't get a job. You're having relational problems. That's appropriate. It is appropriate to feel these things deeply and have them affect your life. It is when it continues for too long a time and causes you impairment that it becomes a problem. And we now have what we call an atypical depression. And the atypical depression is a fairly new definition. And basically, in the atypical depression, what we see are very similar to what we'd expect in a melancholic depression. That is a lack of energy, frequently weight gain along with that. Often people with atypical depression report heaviness in their limbs, so what we would call psychomotor retardation. But along with that, there is a almost paranoid-like sense of reactive or reaction to criticism. And so this is a fairly new condition that's been identified. It's actually not strictly speaking, in the diagnostic books yet, but it's a fairly new condition. So that gives us a broad range of depressive considerations. Any and all of them can be hugely problematic for the person suffering from them.
So I want to circle back to something that you said, because although we see typically depression as something negative or shadowy, it does have a useful purpose, as you said. I mean, there are some positives occasionally to depressive states, right? So if you lose an animal or you lose something natural occurs, or puts you in the natural state of depression, that's actually good for you, right? In a way, it's sort of protective for you.
Well, it certainly can be. Certainly, again, it depends on how much impairment it causes. Actually, at the risk of becoming far too popular in this, if you saw the recent film Inside Out, I would tell you that the emotion of sadness suffers from dysthymia. She's constantly depressed, but what we see in the film, and it's not a bad argument in the film, that sadness and depression and being depressed does have value. The great clinical psychologist Carl Jung suggested that depression was a call to go inside, to give yourself the time to feel, to understand your feelings, to be with your feelings, and to understand unconsciously how those things are affecting you. So he saw depression, any of the depressions, as a call to pay attention to yourself and give yourself the time to process. So yes, depression can have, and does have, again, if there is somebody who lives without one spectrum of emotions, if you live all in joy all of the time, perhaps you've had an extraordinary and blessed life. I'm very glad if that's the case. Most of the human beings I see and my own experience of life tells me we don't always have that. And that there are appropriate times to be depressed, to be down, to be tearful, to be sad. But again, it is when it continues too long, and it's when you can't escape that. And then it is a problem.
Yeah, I mentioned that. I paused to mention that just because I think reframing it is helpful to people in naming it, and being able to come forward with whether it is a problem or not, but just to be in the presence of what is going on with them.
Yes.
Rather than stuffing it down and then it manifesting some other way that will actually hurt them, like maybe physically or something.
Certainly that can happen.
So along those lines, what are the effects of depression? Or what can be the effects of depression?
Well, on the person themselves. Now, again, obviously...
Well, I think we should look at the person and then also the people around them.
Sure.
Yeah.
Ultimately, when you think about the effects of depression, I mean, to some extent, you're just thinking about how you are affected by those particular symptoms we talked about. So if you have 5 of those symptoms, how is that going to affect your life? Well, it's going to make it very hard for you to function. There are depressed people who manage to even function at very high levels. But the cost to them, the stress, and all of the related stress disorders, including problems with blood pressure, cardiac problems. We find that people who are depressed tend to have some suppression of the immune system, so you're more likely to get sick. You're obviously going to have problems maintaining relationships, because frequently the experience, again, depending upon how particularly acute the depression is, it's very hard for you to experience what somebody else is bringing to you. So if you come and you say, "Hi, Joe, how are you doing?" and I'm depressed, it may be very hard for me to meet your mood and to be in rapport with you. You seem to be having a good day, and to me, the whole day looks black, and it just gets blacker and less happy and more damaging. And that can be terrible, right? So that's going to affect our relationship, particularly if you don't know I'm depressed, particularly if you don't understand. You're going to wonder why it is I'm not happy to see you, why it is I'm not willing to enter into a conversation with you or have or share whatever the day's experience should be, and why I'm not there for your emotional reality. Frequently, with depressed parents, we'll find children who behave in the same way in the effects on them that we would expect with a narcissistic, a very self-concerned or self-centered parent. And that's not because the depressed parent is self-concerned or self-centered. They just can't reach the emotional reality of the child. And so the child feels alone and devalued and unseen. So these things can be some of the effects. Of course, that's going to affect your job, your work situation. And the worst effects, of course, are suicide. And studies vary greatly in terms of how depression increases the likelihood of suicide. But the truth is, we suspect, and we all believe, I think, in the field, that most suicides are suffering from some form of depression. So that's hugely problematic.
So I want to circle back to something that you said, but I have to take a short break for our sponsors.
Sure.
So we're going to take a short break for our sponsor, and we'll be right back.
Hi, welcome to Adelante. This is Adelante Recovery, and my name is Yvette Kuglin, and I'm part of the staff.
Adelante Recovery Center has helped people in dual diagnosis for 5 years. We accept most PPO insurances and provide luxury accommodations and 24-hour support. To speak with an admissions counselor, call 1-888-242-4450.
A lot of time we don't even know what's wrong with us, and sometimes we need to get away to figure that out. So if you want to go for a little retreat out in Corona Del Mar, which is a confidential location, we're here to help. So we're only a phone call away. Thank you.
Welcome back to Muslims and Mental Health. Today we're discussing what is depression with Dr. Joseph Futerman. So I'd like to continue now and circle back to what we're talking about before the break, and because you mentioned something about parents who might be depressed and not able to reach their children. And it occurred to me just to highlight perhaps that this could be critical when we're talking about postpartum depression.
Sure.
Because of the attachment, right?
Absolutely.
I was just wondering if you could say something about that.
Well, and again, the problem is getting the population to study. So studies vary. But the issue is that immediately after birth, there are very significant attachment needs that a child has. And those needs are hugely important to determining how they're going to relate to people for the rest of their lives. Because the patterns we set generally at that time in terms of attachment are literally the basis of how we create relationship later on when we are during middle and late childhood, adolescence, and then of course during adulthood, and that can affect the ongoing relationships. If your mother, because she is suffering from a postpartum depression, is unavailable to be there, then the experience that the child is having, and again, this is an infant who really doesn't understand and is not capable of understanding. They don't get why mom is not present for them. We know, for instance, that during feeding, the eye contact between the mother and the child increases the level of several different hormones, but particularly one called oxytocin, in both the infant and in the mother. If that doesn't happen, oxytocin, there are a couple of psychopharmacological researchers have called oxytocin a sociabilizer. Say that one 3 times fast. It is a hormone functioning in the body that really creates feelings of love, of comfort, of safety. These are all present, and to say it creates it is probably a misnomer. Let me say it is present and contributes to that experience. Now, this seems to be based upon literally eye contact, that we have appropriate eye contact with mom while we're being fed. Mom's looking down at us, smiling at us. I'm looking up at mom, smiling at mom. It could just be gas, but I'm smiling at mom and I'm happy. And the problem is if mom is depressed, she may have trouble with that eye contact or the face that the child sees. Because one of the first things that children recognize is the mother's face. The face that they see may be one that consistently projects sadness or discomfort. The sense of the mother being present with the child. So literally, this affects brain chemistry. This affects the chemistry in the body. That can create huge problems. Then later, when I'm supposed to be staring into my lover's eyes and speaking to them and loving them, I may not be capable of doing that. I may have no experience of that. Because, of course, we also find that when people fall in love and stare into each other's eyes, what do we see? Higher levels of oxytocin. If that has not happened, if I don't know how to process that, just at that level, at a chemical level, to go into the rest of the attachment deficits that can occur would require us to go actually into the whole basis of attachment theory. And I think that might be beyond our subject today. At this time.
Yeah. I myself have read some research recently about prenatal care and how they are discovering mental illness starting in the womb because of stress that the mother feels or depression, sadness. And I just wanted to highlight that because I think that a lot of people think you get this later in life or that but this starts early, and people can do things to help decrease it or minimize it, or not in a bad way, but to help affect it positively.
Well, I mean, when you say you get it early, there was a recent study done by a British group where they think they have actually found a genetic propensity for depression. And the information indicates at this time they have found this particular gene in, I think it's 40% of depressed individuals. So that's a fairly high percentage. It argues for a genetic propensity for depression. It wouldn't say necessarily that you are, just because you came from people who were depressed, you're going to be depressed. But it certainly could affect that.
Which is great, because I wanted to ask you next about the causes of depression.
Well, there are several theories. The dominant theory at this point is referred to as the Monoamine Hypothesis. And that theory is that certain neurotransmitters, which are of the class called monoamines, particularly you're looking at serotonin and norepinephrine as the particular ones, are in lower supply in people who are depressed.
So glad we got to a word that people have heard before, serotonin and norepinephrine. The other one is a little harder, I think, for less familiar probably for people. Yeah.
And so that's the dominant theory right now. However, we know, because psychopharmacological research doesn't always work fully effectively, or particular psychopharmacological agents don't work effectively, that there seem to be other factors involved. So we assume that there are environmental factors. Again, there may be genetic factors. All of this is at this time in the thinking about what causes depression. Now, again, there also can be situational depressions that become problematic. So someone starts having a good reason to be depressed, if you like. And then what happens is they move from there to someplace else where, again, they can't move out of the depression. So
I want to go back to just clarifying for our general audience, environmental factors. Because sometimes people hear the word environment and they automatically attach it to just the environment.
Right. Aluminum cans are causing depression.
So
that's not true. Nobody believed that.
Bit more closely at that, because if you could say a little bit more about that.
Well, environmental. When we speak of environmental factors, we're talking about both social psychological factors, as well as possibly physical factors. Most people think of environment just in terms of the physical situation. We don't usually mean that. We usually mean psychosocial factors, by which we mean, again, relationships. One of the things we know is that people who are in strong relationships are less likely to be depressed. Not impossible by any means, but strong supportive relationships. If they are strongly negative relationships, your likelihood of depression obviously goes up. Again.
Which is why we see sometimes, even though you have an environmental factor like poverty, but they have strong bonds with people, they're not depressed.
Exactly.
Or the opposite, of course, where you don't have those and you have some traumatic event or something. So you'd have trauma and depression.
Right. And so these factors, these literally psychosocial factors, act in some ways prophylactically against depression. They act to keep us from experiencing depression. Again, activity, just having things to do. If you are alone, sitting in your room by yourself, there's more of a likelihood that you're going to be depressed. Now, that may be mediated some by whether you're an introvert or an extrovert. Introverts need a certain amount of time alone. So we don't want to pathologize the introvert who needs quiet time.
Right.
And we want to make sure they get that because they need that to feel healthy. But again, supportive relationships or non-supportive relationships. Factors like poverty certainly can affect you, but that depends on what your expectations are. Some of the most interesting work, not on depression, but on happiness, which is not an exact opposite to depression, but certainly goes the other way, comes out of studies of Finland. And one of the things that those studies have shown is that their expectation is less. So if I'm in poverty, but I expected to be rich, I'm far more likely to have a negative experience. If I'm in poverty and I didn't expect to be rich, then it's more acceptable to me. So that idea actually of expectation can certainly be a contributory factor. What is my expectation? And has my expectation been disappointed? Can be a contributory factor in that sense.
Yeah, I think even along those lines, awareness, right, as well, because I've seen people who are impoverished but didn't know they were impoverished. I mean, they didn't know society was defining them as impoverished, and they didn't feel impoverished,
Right.
even though socioeconomically they fit the definition. And so it really wasn't a problem for them.
No, wasn't a problem, and therefore not something that's going to stress them and lead towards an experience like depression. So
it's very interesting. So we talked about the symptoms of depression, but I want to ask you for the viewer, what are signs that would signal I really need to get help, or ones that a loved one would recognize as I need to get help for my loved one or friend?
I think the first thing is to recognize that we need to be talking not about a reactive experience, but about a mood. And mood is a pervasive state. So the first sign is that this goes on for a while. Now again, for a major depression, we need to be looking at least 2 weeks during which the majority of every day is spent with symptoms. So we're looking for people who are very sad, have very low self-esteem, guilty, and can't let it go. Can't do anything else. Again, suicidality. If somebody is talking about it, to say, I'd kill myself if that happened, that's not talking about suicidality. But to say, I can understand why you kill yourself. To say, I can understand what it is that would drive somebody to that. If somebody says, well, if I were going to kill myself, I'd do it this way. And you think about it and you realize that they're actually telling me something. Those are the places where I would begin to become concerned again. So a long period of time where somebody is down, and the discussion of the idea, particularly going to how they would do it, how they would commit suicide. That's when I become somewhat worried and where it might be appropriate to get a professional evaluation.
Okay. And so what are some of the treatments for depression?
Well, the first treatment these days usually ends up being psychopharmacology. We use SSRIs and SNRIs these affect, again, serotonin and norepinephrine levels. And frequently people end up getting those treatments not from a psychiatrist, but from their GP. Actually, the largest prescribing specialty amongst physicians is gynecologists. Prescribe more antidepressants than any other medication. I think that if you're truly suffering from depression, you are best served by actually seeing a psychiatrist. Often those treatments continue to work better. Evidence shows that they work better with talk therapy. So actually seeing a therapist. Again, a reputable therapist will talk to you if you come in and are depressed about whether psychopharmacological interventions seem appropriate to them and may refer you. So if you're seeing, for instance, an MFT, they can't prescribe, or a clinical psychologist, neither can prescribe at this point, but they may refer you to a psychiatrist if they feel that's appropriate. In cases where we've tried everything to treat depression, and I have worked on a couple of these cases, the next treatment used to be ECT, electroconvulsive therapy, literally shock therapy. And shock therapy is very effective. Unfortunately, the side effects are problematic: memory loss. Sometimes there can be some cognitive effects and some motor effects. Far less than it used to be. It's not what it used to be in the 50s. They have it down. We have learned something since then, thank goodness. There is a new treatment, transcranial magnetic stimulation, shows some positive results. The studies are mixed on this. However, they're doing that, and basically what that is they put a large magnet next to your head and stimulate the particular parts of the brain with magnetically with this magnet and those particular parts in the amygdala and in certain areas of the midbrain that we think are significant in depression. And so that's a brand new treatment, brand new, in the last 10 years, but studies are very mixed on results on it. So, but if medication and talk therapy hasn't worked, and you really are somebody who is debilitated by this, I probably would recommend TMS first, and then if that doesn't work, ECT. And I have on only a couple of occasions. And it is a hard decision to make because we all have those pictures left over from One Flew Over the Cuckoo's Nest and things like that that are nightmarish, and it isn't that these days. So
I think one thing to just highlight is the benefits of talk therapy.
Absolutely.
Because I'm not sure that the general public is aware of how talk therapy itself can rewire connections.
I think you have to, the interesting thing is, if I give you a medication and that medication makes a chemical change, and I take away the medication and the chemical change stops, if the behavior is based upon the chemistry, then your behavior is going to go back to whatever it was. Talk therapy, the interesting thing is we continue to believe that memory is stored in the central nervous system somehow. Well, if that's true, then the conversation you and I are having, if we're going to remember having had this conversation in 10 years, something in my brain, either the chemistry or the anatomy of my brain has to be shifting right now. You're doing this to me. You're changing my brain. And hopefully I'm changing yours. And maybe we're changing people's brains out there. That means if this is going to be remembered, we actually are making, and again, long-term, permanent changes to the brain, or reasonably permanent changes to the brain just by having this discussion. Mm-hmm. Now again, so say we decide that you need Prozac. You've come to me, you're depressed, we're going to do talk therapy and get you started on Prozac. You go to the psychiatrist says, yes, Prozac, makes the decision, gives you the script, you get it, you start taking it. So we've begun to change your brain chemistry. You're getting more serotonin in the synapse, everything's there, you say it's working, you feel better. All of that's fine. What we're hoping to do by giving you that, either we have to give you that for the rest of your life, which is not desirable from a cost perspective, from a perspective of you having to remember to take a particular medication, etc. What we're hoping to do is to help you build those new permanent pathways, those pathways that change things. And so talk therapy does that by itself. At this point, we don't see that there is that there are significant changes. What we will see with psychopharmacology is remission. Mm-hmm. And that remission seems to go on for a while, but frequently people will then have another episode. So the question is, which is more effective? And there are lots of studies out there. It kind of depends on who is doing the study, how the results come out. We don't know. The best bet is to see a therapist who is willing to do talk therapy with you and consider the possibility of psychopharmacological intervention and help you work with that responsibly.
So I hesitate asking this question because of all the factors that affect one's diagnosis of depression. Mm-hmm. But are there preventative steps that people can take to avoid depression?
Well, that's a really hard question to answer. Mm-hmm. Because preventative steps assumes we understand cause. Mm-hmm. And we don't fully understand cause. But again, I think that the most important steps are stay in relationship to people who you care about and who care about you. Get an appropriate amount of exercise, Yeah,
we recently did an episode on food and mood.
There you go. Work together ultimately with people in your life to take time to do things you enjoy. I mean, you don't have to be hysterically happy. As a matter of fact, if you're hysterically happy, we may want to treat you for other things. But bottom line is we all need a certain amount of positive time with people we care about and who care about us. We all need a certain amount of the things. Define the things that you enjoy. Remember, one of the symptoms is anhedonia, loss of interest in pleasurable activities. It's much harder to tell whether you're depressed if you don't know what your pleasurable activities are. Mm-hmm. But if there are things you enjoy doing, whether that's walking the dog in the morning, whether that's going out with friends and doing activities, whatever it is, do those things, cultivate those things, make time for those things. Life gets busy. There are times when you can't do much of them, but know that you want to get back to them and have a plan to get back to them. And that really, the engagement in life with the rest of the people around you who are part of your life is probably the best preventative. I wish I could tell you that there's something you need. Stay away from broccoli. I wish I could say that, but there isn't. And broccoli's probably good for you.
Yes,
it's a cruciferous vegetable. Although there are 4-year-olds out there right now who are going, broccoli causes depression. No. So there aren't really a regime that will do that for you. But again, engaging in life with the people you care about and who care about you.
And so I just want to turn briefly to the people that care about you and ask how depression typically affects those around you when you're suffering from depression, and also a sort of larger big picture view of how it affects society in general.
Well, I think, let me take the society piece first. I think you touched on that when you said $30 billion in losses. And those losses, you didn't kind of deconstruct that. Those losses are due to lost job hours. They're due to lost income and therefore lost taxes. They're due to the losses associated with having to treat people who attempt suicide, the losses inherent in people who manage to complete a suicide. So all of these things affect society. I think that there are hidden effects, and to do that, we have to talk a little bit about the people we care about. When I'm depressed, essentially, if you think about it, if you're having to interact with somebody who is constantly negative, constantly in discomfort and pain, and I care about them, then I really have only two choices. I either can disconnect from them, or I can ultimately be there with them, but that shouldn't be enjoyable time.
Right.
And that's going to increase my stress level. It is going to decrease my capacity, therefore, to be resilient in other circumstances. These things, even though it may be a sister or a brother or a parent who spends time with the depressed individual, the effects of that time spent with that person ripple out through the rest of the family because they're less resilient. They're more concerned. They're more worried. So we're going to see increased stress. Along with increased stress, the people who are closest to us are going to suffer from immunosuppression. Their immune systems are not going to function as well. We simply know that long-term exposure to stress hormones makes your immune system not work as well. You are going to see, obviously, in extreme cases where this goes on for a while, more marital discord, more frequently children of depressed parents, or in a relationship where you have one or another depressed parent, act out. They act out because they are not receiving appropriate attention. You may also, to some extent, there is a contagion of depression. And this is not to say that there's a virus there you can catch, but it is the very rare individual who can be with someone they care about who's depressed and not leave somewhat depressed themselves. So that contagion of depression means that they may move into depression. And we know some of that because, for instance, clinicians are at a much greater risk of depression. Part of it's because we spend a great deal of time with depressed people. Some of it, some people say, is because those people who go into the field start as nuts, but that's only partially true. And it wasn't true of me.
Yeah, okay. So,
Sorry.
yeah, it's not true of me either, I hope. So, but yes, I know, I've heard that many times. People say that about our profession, right?
Mm-hmm.
Yeah. So, okay, so I just want to ask real quick if there's anything else that you wanted to mention about depression. Otherwise, we're going to transition to a few fun questions.
Gosh, I really don't think so. I mean, I think we've covered depression. Let's get to the fun.
Okay, so I want to ask you, who is your hero, if you have one, and why?
That's a kind of a hard question. I have a number of different heroes, and I think at different points in my life I've had different heroes. But I think probably the most enduring hero is Leonardo da Vinci. And it's because he is the ideal of the Renaissance man, the individual who is moved by creativity and the desire to know. And if I can live up to that ideal in my life, if I can live my life that way, then I think I will have lived a good life. That's
okay. And what is your favorite concept and why?
why. I think probably my favorite concept would be the mind.
Mm-hmm.
It mediates everything that is human, and therefore the universe as we understand it. I'm not saying that we create the universe by any means. The universe is out there. But we understand it. We experience it through this sieve, this filter, this device we call the mind. And I want to be clear, I don't mean the brain.
Mm-hmm.
I mean the mind, whatever that thing is. And that's the most fascinating concept ever because it affects every other concept. There's no other idea, no other experience that is not experienced through the mind.
Yeah, it's interesting because as we approach a time in our history where it's difficult to distinguish a lie from the truth.
Yes.
The battlefront, let's say, is in the mind. It's no longer about, although we have that, it's not really about the swords and the guns and everything, although that's clearly an issue. The battlefront is really more at the mind level at this point.
I think so. I think that we need to bring more depth of understanding of the mind to what we're doing in all things, but no place is more important than at the places where cultures and communities interface.
Mm-hmm.
Because we walk in thinking we know what it looks like. And the truth is, you have to see from both sides.
Mm-hmm.
The minds are different.
Mm-hmm.
Every mind around yours is different than mine, and mine is different than yours. And that allows us to disagree. It allows us to get excited about. But there's no way I can just say of my mind, and I'm only talking of my perceptions, that those are more right than yours. I can say simply, you have your perceptions and I have mine, and we don't know.
Mm-hmm.
And can we build trust and care out of knowing that we don't know? And that, I think, is crucial. And if we could bring that perspective to a whole bunch of the circumstances that the world finds itself in out there, I think we would be doing much better. Mm-hmm. I think if we could start teaching this I want to teach people about and the notion of the mind and that inherent idea in terms of perception versus sensation in grammar school. I think that's where we need to start teaching it, which is going to be really hard when your kid comes home and says, well, that's not the way I see it.
And some of them do that.
They do. Yes, my daughter did.
And so lastly, what is your favorite word and why?
I think my favorite word would be obstreperous.
Okay.
Well, because I think that should be the essential quality of humanity. We have to ask questions. I don't believe that the universe, that divinity, that God, that however you conceive of it in your mind, has a fear of our questions.
Mm-hmm.
I think I never had a fear of my daughter's questions, even though she asked some I still don't know the answers to and probably never will. And some I don't want to know the answers to. I hope that that's the attitude of the universe. And I think to be obstreperous, to say, why? To point out the emperor has no clothes, to be the one who does those. And that's what I think, again, to do that is about living life well, and about making the contribution that I think every human being can make and should make. We need every human being's contribution, all of us, all the billions of us who are out there. So they all need to get a little more obstreperous, step out of where they think they should be and say, well, why? I want to know why. You know, I really do believe, and in my classes, I certainly try to teach from the perspective, almost all professors say, there are no stupid questions. I don't think there are. I really do. Every question. And the simplest question is the hardest. Why? Why? Anybody who asks me that repeatedly, I'm good with. Even though they may be a pain, I'm good with.
Okay, well, that's great. Thank you so much for taking the time with us. This concludes another episode of Muslims and Mental Health. As always, we appreciate your comments, your feedback, your concerns, and you can send those to nafshealertherapy@gmail.com. That's NAFSHEALER therapy@gmail.com. And also join us on our adjunctive website at www.nafshealertherapy.wordpress.com for PDFs and podcasts. Thank you. And I just want to also highlight that later on this month of September, we will be having a show on suicide prevention. And September 10th is actually Suicide Prevention Day. So Google it and find out where you can participate in activities and light a candle for someone. Thank you.